So now we're going to try to practice some of the principles we've talked about in form of some questions and activities. The first type of question I have for you is a matching question. Question would look at the different forms or the different organisms and the different types of pneumonia that we're likely to encounter. So we're trying to match the two columns with one another. So when you hear atypical pneumonia, which option on this column, so let's call them column A and column B, so it's easy for us to communicate here. So when you hear atypical pneumonia, which germ organism in column B would apply to this? I'm hoping that you're thinking mycoplasma would be the answer. All right, how about bacterial pneumonia? Which would be the correct answer for bacterial pneumonia? Well, when you scan the list, option A, Streptococcus pneumoniae, that's a bacteria, and it's actually very common. When you look at option D, Staphylococcus aureus, another common bacteria. And then option E, Pseudomonas aeruginosa, that's another bacteria. Now, this is actually, option E, Pseudomonas, is an interesting bacteria. For those of you who have done any rotation, any work in burn units, you probably remember hearing that flowers are not allowed, fruit baskets are not allowed, really anything with fresh water is not allowed. That's really where Pseudomonas, the bacteria, lives. For someone who had a severe burn, it means their physical barrier, their skin, is not there anymore. So that could create some high or increase the risk for their infection. So Pseudomonas that lives through fresh water is not allowed in any water medium to be introduced in burn units. All right. Immune-compromised pneumonia, that would be option F, which is a type of fungus, Pneumocystis jirovecii or jirovecii. Hospital-acquired, that would be Staphylococcus aureus, because it lives in the skin, so it could contaminate everywhere, from patient charts to tools and so forth. And then Pseudomonas aeruginosa would be the other option. So I have kind of drafted an answer key for you just in case you missed something I said, to be able to tell which is the right answer for which. Another question or group of questions that we need to address together is to tie in how does pneumonia kind of stack when it comes to the framework that we've looked at. So the first kind of question I have for you, now ordinarily we do this as a pair share activity, is which areas in the framework, I'm specifically, if you have the framework in front of you, I'm specifically talking about the white boxes on top. Which of these determinants may be impacted by the process of pneumonia? So again, you can pause the video to think about it a little bit. I'll just move on and discuss how. So I put in the areas, I noted the areas that could be affected. Compliance is one. Obviously, when the lung is inflamed, the stretchability of that lung would be impacted. The diffusion distance, we said, when the alveoli are full of pus and liquid, that will make it harder and longer for the oxygen to travel into the blood vessel. And then the surface area. Why surface area? Well, because let's say normally we have 100, that's just a random number, 100 empty functional alveoli. If all of a sudden we fill 50 of them with liquid, well, now we're down to 50% of our functional capacity. So those are the key areas that could be impacted by the process of pneumonia. Now, the first activity we've done today was to go back to this same framework and see how something like COPD impacts it. And now we've done the same by looking at how pneumonia impacts it. So can we then start comparing COPD and pneumonia? How would they be similar? How would they be different in terms of how they affect the framework? Now, as you remember learning in previous classes, one of the easiest tools we can use to compare two things, especially if they share something in common, is to use a Venn diagram. So we're going to use pretty much the diagram here, and we're going to look at how they differ. That's how they're different, and in the middle we'll put in how they're similar. So again, I want you to pause the video, think about it a little bit, see what you can come up with before moving on to see the correct answers. So here is what I could come up with in terms of similarities and differences. Again, let's look at the middle portion where, they have a similar outcome on the framework. Both of them can impair ventilation. Both of them can impair diffusion. How they do it is going to be a little bit different, but eventually both ventilation and diffusion are affected by the two pathologies. Now, the next thing on our list will be the pathology related to pneumonia as a whole. Before we start looking into the details here, there are a few things we need to make sure that we're all on the same page. Your course, NK2, is an integrated course between the sciences and the nursing program. So what we've talked about so far were the key clinical, pathophysiological, integrated with NK1 principles that are really crucial for your understanding. What I'm going to discuss with you now is pure pathology. This is not going to be something that we directly test you on. It's not something that I expect you to memorize or know all the details. We want themes. We want to see how this pathology that we're learning about would resonate with our minds. What are some of the take-home messages, the key points about them? Part of our pathology discussion would involve looking at pathology pictures, either at the macroscopic or microscopic form. Keep in mind that none of these pictures will be things that we test you on in the exam. The only reason I'm showing them to you is to make the text a little bit more easy to interact with. When you read a text about how, let's say, there are white blood cells in the alveoli, that could be something that, some students will struggle visualizing. So I'm showing you a picture just so you can have a visual of it. But again, none of the pathology details would be examinable. None of the pictures we see in pathology are examinables. They're just to ensure that you have a wider understanding of the key principles related to what we're learning about. So from a pathological standpoint, pneumonia usually goes through phases. In phase 1, which is something we call the congestion phase, the lung is usually heavy because it's full of water, and it looks congested too. After that, all the white blood cells and other blood cells will start to infiltrate the area. So that would include neutrophils, a white blood cell, red blood cells. So we say the lung is in the red hepatization phase. It's just a name. After that, things will start to the inflammation would begin, the white blood cells will try to neutralize some of the invaders, and we start to see a grayish-brown surface. We call that the gray hepatization. And finally, we start the cleanup process. Let's say the white blood cells won the battle, now they're cleaning up to restore the normal anatomy. We call that the resolution phase. Now again, those details, those 4 steps, the technical terms, is not something that I would expect you to know. But why am I showing you this? Earlier in our discussion of pneumonia, we said it's an infectious/inflammatory process. So really, when you look at all these 4 phases, they're just a detailed version of saying inflammation. Inflammation, you have an injury, you bring white blood cells and blood cells into the area, you kill the invaders, and you start to repair. Look at those phases again. Congestion, we're bringing blood, we're bringing cells to fight and clean up, we win the battle, and we start restoring the normal anatomy. So the theme has retained kind of the overall definition or statement that we made earlier. Now here, it's very easy to tell that there is one part of the lung that is impacted, that is not normal. Now again, we're not getting into the detail of this, but the reason I'm showing you this is because I'm trying to coach you into exploiting these things, these little details into your clinical world. So you are a clinician, you'll be in the hospital, you won't be able to see someone's lung like this, but is there something you can do to gauge, to assess someone's lung that is heavy and full of water as opposed to healthy? Yeah, you can always use your stethoscope. If you put your stethoscope on a healthy lung, you hear the air moving in and out. But if you put your stethoscope on a lung that is full of water, the quality of that air is going to change a little bit. Now, in next week's lecture, when you do the nursing piece of pneumonia, there will be a series of audio files that you will hear, and you'll start to differentiate between a healthy and a non-healthy lung. So this is the story at the macroscopic level. How about at the microscopic level? If we take a section, put it under the microscope. Well, earlier we said that in typical pneumonia, the infection, the inflammation is confined to the alveoli. So that means white blood cells travel to the alveoli, they start the fighting process of bacteria. So there'll be a lot of mess in the actual alveoli. So let's look at a couple of pictures here. This picture shows you a normal alveolus. Trace it on the screen. This is the alveolus. It's just an empty space. That's how we need our alveoli to be. That empty space is loaded with oxygen, and that oxygen can just move into blood vessels easily. Okay? Now, look at this picture here. Let me highlight where the alveoli are. This is one alveolus. This is another alveolus. This is another alveolus. Another one. Another one. What do you notice compared to the normal? The alveoli are not empty. The alveoli are full of these dark circles. Those dark circles, by the way, are white blood cells. When we see white blood cells, we immediately know that there is infection and there is inflammation going on. So it looks messy. And that's really the key point I want you to remember, that even at the microscopic level, we're jamming, we're filling the alveoli with liquid, with white blood cells, so that would complicate gas exchange as a whole.